I have reported the study concerning implementation of the diagnosis of acute myocardial infarction very quick in the emergency department, trying to identify as soon as possible the patients who doesn't have an acute myocardial infarction. They have chest pain, but they don't have the probability to be suffering of a myocardial infarction and can be easily discharged and sent home safely, let's say, so without being at risk of major adverse cardiac events in their early future, while recognizing the one who have from the very beginning a clear diagnosis and the other one who are in the so-called observational zone. They cannot be discharged, they do not have a final diagnosis, but the probability to have a myocardial infarction is still there, and only those one deserve to stay in the ED. They don't have to lose their ability to listen to the medical history of the patients and do the first medical examination and be able enough to let's say, enough to interpret the EKG. But even if they do that in few minutes and very well, there are some patients where the diagnosis is not so clear. So we have the biomarkers, we have some biochemical assay that allows to us to see whether there is a myocardial muscle suffering. Detecting these substances that come only from the myocardial cells and are present in the circulation very early. And now we have this high sensitivity troponin assay that allows to us to detect very low level of these biomarkers. But we have to use them very, let's say, smart, because if you look for troponins in patients not necessarily arriving for a chest pain, if they have a systemic inflammation, for example, or they are arriving for a cardiovascular disease like acute heart failure, they could have troponins in the blood, but they are not suffering of a myocardial infarction, so they deserve a completely different diagnostic flow chart. So the problem is to associate medical history, physical examination, so a pre-test, let's say, probability to be a patient with a myocardial infarction with the assay. And now we are trying to implement the specific assay, finding out in a population of patients arriving with these characteristics, the ones who can be, let's say, where the diagnosis can be ruled out in 1 hour. This could be a great advance in science, because if in 1 hour you can identify something like 56% out of 100 patients with a suspected acute myocardial infarction and send them home, you will not have the overcrowded emergency department with the doctors becoming crazy, the patients becoming anxious and not receiving the proper therapy for their condition. It's not available everywhere. It's expensive to perform a CT scan, for example, in all the patients where there is the suspicion, but we are not sure. It's not so safe for the patients because they receive a lot of radiation. So I think that this technique will be used only in a small proportion of patients where there is not the possibility to say, oh no, the patient doesn't have a myocardial infarction, or the patient has a myocardial infarction. But in the middle, where you need a longer time to observe the patients, and you could have a good reason to expose the patients to X-ray or to send the patient to another hospital to receive a CT scan just to arrive to the final diagnosis, or because you are suspecting something else like aortic dissection, for example, and in that case CT scan is important. This proportion of patients on the basis of the last trials is around 24–30% of the entire population arriving for chest pain. So it's a small proportion compared with the 100% of patients arriving. I think that in the emergency department there are other imaging techniques that can be used by the ED doctors, by the emergentists. like echo, for example. Echo is becoming more and more diffused, not only for cardiology, not only for the cardiovascular problems, but also for many others. But echo is cheap. It's easy to become smart enough to use an echo device in the ED. So in that case, imaging can be extremely important and should be implemented everywhere. But CT scan is not present everywhere, and not everywhere there is a radiologist expert enough to interpret for that disease the result of the exam during, for example, the night or during the weekend. That's the problem. When you are in an emergency department, the technique that you use should be the same, with the same accuracy, every single hour, 24 hours per day, 7 days per week. And so otherwise it's completely useless.